Welcome to the His Health webinar training series. We are so excited today to be discussing improving access to care, lessons learned from designing, implementing, and evaluating the Indianapolis, Indiana's Linkage to Care program. And today we're very, very grateful to be joined by a longtime CBAC and His Health collaborator, Abbe Shapiro, who currently works as a routine HIV screening coordinator at Eskenazi Health. Abbe has worked for many years in the field of HIV, developing national HIV prevention strategies for use in NAMBIA, HIV-specific educational materials for future dentists at Indiana University, and most recently conducted a 3-year pilot Linkage to Care program in Indianapolis, Indiana, which we'll talk about in great depth today. This federally funded linkage program focuses on the development of best practices for ensuring that all people living with HIV enter or re-enter and maintain an HIV medical care successfully through the provision of wraparound services and collaborative community care. Abbe, thank you so much for joining the webinar today.
Absolutely. Thanks for having me.
Awesome. So today let's just run through the agenda today. We always like to start our webinars with a little bit of background on the His Health resource, and then I'll pass the baton to Abbe, who will go through a comprehensive overview of the L2C or Linkage to Care program, discussing also program development and design, essentials of staff training, data collection tools, and as well as evaluation tools. And then we'll close with about 5 to 10 minutes of Q&A. So I'd like to start with a little bit of discussion on the impetus behind developing this resource. As you know, we are collaborating with the Health Resources Services Administration's HIV/AIDS Bureau to create an online learning resource that targets providers and helps them to access resources and training and cutting-edge strategies for improving the standard of care for Black gay men. In terms of how His Health identifies, we identify as just that, a community of advocates and healthcare providers who are passionately committed to improving healthcare access and the quality of healthcare for Black same-gender loving men. We firmly believe that shifting the HIV epidemic is a shared responsibility amongst patients, providers, and administrators operating at every level of our U.S. healthcare system. So in terms of what we'll be offering with products on His Health, hishealth.org will launch this summer at about mid-August. We'll be featuring a cohort of efficacious care models and strategies that have shown great promise, not just for HIV linkage and retention, but also around sexual health service provision that is affirming of the personhood of Black gay men. Additionally, we're excited to create an original cohort of continuing medical education courses that are fully interactive and 100% free. It's 4 hours of CE training, and they can all be accessed online at hishealth.org. And our last goal is really to use this platform to reach as many patient, provider, and public health communities as possible. So, Abbe, I'm going to actually turn it over to you now to dive into an overview of the Linkage to Care program, and just say next slide when you need me to move it forward.
All right, great. All right, so I'm going to talk about the Linkage to Care program that we started in Indianapolis a little over 3 years ago. So if you want to go ahead and flip to the next slide. This was an 18-month research project that was funded by AIDS United along with a local funder, the Health Foundation of Indianapolis, Indiana AIDS Fund. The L2C Program Objective was, and I'll just read this quote straight to you, to provide individualized support to clients, helping to identify and eliminate barriers to care so that clients can achieve success in treatment and optimal health. By partnering with key agencies in the community most impacted by HIV, we were able to tailor linkage support to clients' needs in a culturally sensitive manner. So I'm going to get into a lot more depth about the program itself, but that kind of gives you the real broad overview of the program. We focused on 2 specific ends of the spectrum of people who are engaged in care. So people who were newly diagnosed, ensuring that they had adequate and more support than was traditionally given to people in Indianapolis who were newly diagnosed, ensuring that they had adequate support to enter into care successfully and then maintain in care. And on the other end of that spectrum, we sought to locate people who had fallen out of care So specifically people, because this was a research project, that meant that they had been out of HIV medical care for a year or more. So trying to locate those people, work with them to identify what were their barriers to care, and then systematically eliminate those barriers so that they could re-enter into HIV medical care and maintain in medical care successfully. And the program itself was extremely successful, is extremely successful, and I'm excited to share more with you about that. Next slide. In terms of program design, our staff, so I myself was the program manager. That meant that I was responsible for developing the program itself and implementation and all the research components of that. I was also responsible for staff training and support, as well as quality assurance of all of the data that was collected. We were fortunate enough to have 4 full-time linkage to care specialists, and each of them had their own focal area. So we had one that was placed with the Indiana Latino Institute. We had one that focused on serving women of color. She was placed at a very small local agency called Women in Motion, and that agency focused on providing wraparound health education programming for women of color. We also had one linkage specialist who had a specific interest and skill set and knowledge around serving the Black MSM community, and that he was placed with an agency called Brothers United. They do AIDS service, or they're an AIDS service organization that serves mainly young Black MSM as well as the transgender community. We also had another full-time linkage specialist who was more general, and we were able to connect him with, I don't know, any of the clients that got engaged in the program, and he was placed at the Damien Center where I was placed. We also were fortunate enough to have a part-time linkage specialist who was also placed at the Damien Center, and his focus area was serving youth. Additionally, we had one evaluator, and we worked with collaboratively with Johns Hopkins University to do the federal data analysis. Our agency was one of 13 agencies around the country that were engaged in this research project, though each of our projects were very different in focus. Next slide. In regards to the program design, I guess I spoke to this a little bit just now. So we partnered closely with 4 agencies, and as I said, those are Brothers United, Women in Motion, the Indiana Latino Institute, as well as the Damien Center where I was placed. We very specifically identified those agencies and wrote annual contracts with them to partner with the Damien Center. They were identified specifically because of their unique experience and expertise with their own communities. So Brothers United has a very long and strong history of successful engagement with the Black MSM community, and so we worked very closely with them to ensure that the programming was designed specifically to best serve their community, and then the same with Women in Motion and the Indiana Latino Institute. We really sought out those agencies specifically because we understood that we needed to bring in that collaboration. In terms of caseloads, each of the linkage specialists had relatively small caseloads, and that was purposeful because there was a really strong intensity in the way that they were serving their clients. We understood that for clients who had fallen out of care, their barriers to care were really larger than the people who are successfully in care. And so as a result, when developing this program, we really sought to try to understand the life experience of the clients they would be serving, and that their needs were going to be higher than those of a traditional client. They also were on call, by and large 24 hours a day, so that they could serve people who were newly diagnosed, giving them that really intense connection and building rapport upon diagnosis, ensuring that, when someone is newly diagnosed, that they may be okay with that diagnosis at that time, but when they're up at 3 in the morning that night thinking about that new diagnosis, they're going to need someone that they can talk to. And we wanted to ensure that the linkage specialists were available in that way. Additionally, each of the linkage specialists were responsible for developing and facilitating a support group for their specific focal areas. So understanding that this was something, so our youth-specific specialist did two different support groups, understanding that his younger caseload really wasn't experiencing the same things that his, sorry, I just lost my feed. But understanding that his younger caseload really wasn't working, or wasn't experiencing the same things as his older, still youth-focused caseload, and so he really I understood that he needed to create very specific programming for each of those populations in the same way that at Brothers United, our linkage specialist needed to create really specific programming that was going to best fit the community that he was serving. Next slide. In terms of program goals, there are a lot of program goals, and I'm not going to go through all of these that are in this slide, but I hope that you do read about this later. Ultimately, the real goal of this program was to create very tailored programming that was unique to the specific needs of each of the participants. So understanding that each person's experience is going to be different, their barriers to care are going to be different than any of the other participants. And so really making sure that if you really hear what that client is saying, that program is going to be really uniquely designed for that person based on their specific needs. We also really focused on ensuring that those specific needs were being served by providing the most effective services at the most appropriate time. So not assuming that a client needed to be in care, let's say at the Damien Center, but if they were in care at another site, that we would provide linkage services to them at that other site. Additionally, really trying to focus on those barriers to care that client identified. So ensuring that that if they had if they were homeless and that was their #1 identified barrier to care, then that was going to be the #1 focus for that linkage specialist, with an understanding that once we address their #1 barrier and we're able to get them stably housed, then we'll be able to systematically eliminate other barriers and help them to return to HIV medical care and maintain in care. We also made sure that the linkage specialist assisted with medical adherence, and medication adherence. So that meant that once someone was re-engaged in care and helping them to get re-engaged, that included giving them rides to and from all appointments in the beginning. It meant attending appointments with them, helping them to learn how to be health advocates for themselves, but also modeling that behavior in an exam room. So asking those questions on behalf of a client if needed, or helping them to have the strength to ask the questions that they had been asking, let's say, in the car on the way there. Additionally, it meant calling them on a daily basis to remind them to take their medication, until they were able to do it on their own. And all of this was guided around goals that were identified by the client in collaboration with each linkage specialist to identify what specifically did that client need in order to be successful. And like I said, providing, really being a health advocate for that client and being a bridge between that. There's a lot of people that are involved in the care of a client, so ensuring that there was better communication between the client and the care coordinator and their, let's say, their mental health provider and their infectious disease provider, and making sure that all of those bridges were connected and helping our clients to learn how to do all of that on their own. But understanding that in the beginning that oftentimes there's too many things for our clients to be able to successfully engage in care, and those oftentimes were things that they identified as why they had fallen out of care in the first place. There were just too many things they had to keep in contact with. Next slide. In terms of client eligibility requirements, as I said, we were serving two different populations. So we had to have proof of HIV status, and that was something that for many of our clients they didn't have, and so we needed to have the linkage specialists assist them in obtaining documentation. Additionally, in Indiana, one of the requirements is that they have to have proof of Indiana residency, and in order for them to access HIV-specific insurance. So that oftentimes, those two things were often huge barriers for helping people to get into care, and oftentimes they needed a lot of support in order to do that. If you have to have an Indiana ID, but you have to have a birth certificate in order to get an ID. And so helping people through those steps in order to do that is oftentimes that needed support, and that may be all that a client needs in order to kind of move into doing this on their own. But those appear to be these kind of major barriers in accessing care. Additionally, we provided intensive linkage support to people who were newly diagnosed within 6 months of diagnosis. If they were HIV positive and had never entered care, HIV positive and hadn't seen their HIV medical provider in 1 year or more, if they were HIV positive and had failed to attend an HIV medical services care coordination intake appointment through the means of no-call, no-show, and if they were HIV positive and identified as at intake as being high risk for unsuccessful entrance or returning into HIV medical care. So we had a lot of options for how to engage someone into care, but because it was a research project, there were boundaries that were identified for what eligibility looked like. And as the grant itself ended, we were able to then broaden what eligibility looked like, because we understood that sometimes people needed that extra level of support, and we weren't able to give it to them during the research project. Next slide. In terms of how people were engaged in care, it happened in two different ways for those that were newly diagnosed and those who were out of care. But again, because this was a research project, we had to really specifically delineate what was that process, and that having all of these protocols in place as a result of the research project really helped us as we came outside of the confines of the grant. But in any case, I developed relationships with essentially all of the agencies locally that were doing HIV testing. In that way, we were able to ensure that people who were newly diagnosed with HIV were able to engage in care in a new and more meaningful way than what was happening prior to the Linkage to Care program. What was happening prior to this is that we had anybody who was newly diagnosed in Indianapolis essentially was given a sheet of paper with a list of AIDS service organizations, and as much support as possible was provided at that time. But essentially, the responsibility lied on the client upon diagnosis to engage in care. And we know that oftentimes someone either initiates that or upon diagnosis, or waits a significant amount of time, usually 3 to 5 years, before they actually engage in care. And that's oftentimes once they're starting to have symptoms. And so as a result, we understood that that was how things were going in Indianapolis, and we wanted to shift that into a more client-centered and supportive manner. So anytime that someone was tested and identified as newly diagnosed, they would contact me, and I would send someone out. One of the linkage specialists would actually be dispatched to work with them and create and build face-to-face rapport with that client upon diagnosis. If we weren't able to actually dispatch someone at that time, we were given we made sure that we had contact information for that client, and tried to have contact with them on the phone within 24 hours and schedule a time to meet them during that period of time. The next step of that would be, once the linkage specialist was connected with that client, would be helping them to identify what were the next steps. So helping them to identify what is the appropriate infectious disease clinic that they wanted to attend, helping them to get scheduled, helping them to identify what other needs that they had, and providing really intensive support during that time as well. And then giving them a ride to that first care coordination appointment and that first infectious disease appointment as well. Next slide. In terms of the protocol for out-of-care clients, this kind of goes back to that other slide in regards to client eligibility requirements. And so once someone was identified as out-of-care within those eligibility requirements, then we had a referral form that I believe NASDAQ will be sending to the participants that are here today. And that referral form was pretty specific in terms of getting as much information as possible from the referral source, and that included any AIDS service organization in the area, as well as any infectious disease provider. We also had we built a relationship with various adult addiction treatment facilities where they might come across people who had fallen out of care, as well as homeless shelters and the local free STD clinic, and it's places that we could identify where there may be people who had fallen out of HIV care that may need that extra support in order to re-engage in HIV care. So all of those referrals came through me, and that gave me an opportunity to ensure that someone was in fact eligible for the research project. Additionally, it gave us a chance to connect with that referral source, get more information if possible, and that way I could connect them with the best fit linkage specialist and make sure that we could increase the likelihood that the client was successful in re-engaging care, as well as I also took referrals, actual self-referrals from clients. So if they contacted me directly, or if they contacted one of the linkage specialists having heard about the program, we would just make sure that they were eligible, and if not, we would still help to provide them with needed support to re-engage in care. Next slide. All right, now we're going to move on to the training that I did with the linkage specialist. Next slide. When developing this program, I really sought to look at three specific things in terms of, based on my experience working in HIV and things that I thought were successful, and because I have a master's in social work, that really ended up being the guiding principles anyhow. But I really looked at the social work model in and of itself, where the primary mission is to enhance human well-being and help meet basic human needs of all people, with particular attention to the needs and empowerment of people who are vulnerable, oppressed, and living in poverty. So that really is very much in line if we're looking at major health disparities of people of color who are getting impacted by HIV at higher and higher levels. Additionally, I did a lot of work with the clients with the linkage specialists during training to ensure that they understood that they would likely experience dual relationships, and that they were going to need to establish appropriate boundaries with their clients, because we very specifically sought out staff that was part of the communities that they would be serving. It was very likely that they were going to have, they may encounter these people in their daily lives. And so we wanted to ensure that they had adequate training, and that's something that we actually went through quite a bit and had to revisit over the course of time. So, for instance, one of our linkage specialists, she is at this point 17 years in recovery. She's very well known in the recovery community, and many of our clients are also struggling with addiction. And so making sure that she was able to adequately provide support to them in both of those realms, and understanding that if that wasn't going to be something she could do, that she needed to be able to let me know so that I could connect that person with a linkage specialist that was a better fit, so that she could maintain that relationship with them in the recovery community. That's also something that we came across with our linkage specialist who was placed at Brothers United. He is a young Black MSM of him, and very, very well connected with that community. And so making sure that he, when I would give him a referral, I would always make sure that this was someone that, if it was someone that he knew, that he could take a look at that and decide how will that impact his personal relationship with that person. Will it strengthen that personal relationship, or will it hinder that? And making sure that he understood how to develop those boundaries and make sure that he could maintain those. And I wanted to make sure that I was supporting him in the best way possible to ensure that he was able to make these separations between his work life and his personal life. Also, because they were providing their linkage services very connected with people in their homes, in their communities, with their families, that they had to really understand how to establish those boundaries and maintain those boundaries. And there's also an attachment that I've provided NASTAD with that shows some of the training that I did around ethical decision making, and that's again connected to training that I have in social work. Additionally, we trained around motivational interviewing, and I'll give you a shout out to, we have an upcoming webinar with it's me and Terrell Parker, who was at the time a linkage specialist at Brothers United. It's on July 8th at 1 o'clock, and it's focused on motivational interviewing specifically. So we're going to go into a lot more depth. It's called Utilizing Motivational Interviewing to Engage or Re-engage Clients in HIV Medical Care. Motivational interviewing is a directive client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. I found this to be extremely useful for our clients by really helping to allow them to have a voice in identifying what exactly were their barriers to care, and then to systematically eliminate those barriers, but really providing a focused way for the linkage specialists to ask the right questions at the right time and in the right way. We additionally used a strengths-based perspective, which offers service providers ways to work that focus on strengths, abilities, and potential rather than problems, deficits, and pathologies. So really understanding that the clients that they were serving or are serving have a lot of strengths, and really helping to build on those, and having the training to understand that and to build on that was really useful. Next slide. Next slide. Okay. We also did a lot of training that involved shadowing, and I cannot highlight this enough, is that it was extremely vital to the training for our linkage specialists and to build rapport with the community. So we had the linkage specialists shadow all of the care coordinators in all of the AIDS service organizations in Indianapolis. We also had them shadow at all of the infectious disease provider sites. This allowed our linkage specialists an opportunity to really understand the experience that their clients would be having in these different settings, and it also built rapport with our communities. And that really helped in guiding referrals so that the clients would be able to understand which site would be the best fit for them, because their linkage specialists understood those different sites and understood why those sites might be a good fit for them. On the other side of that, the infectious disease providers and the care coordinators had built relationships with the linkage specialists, so that when they were making referrals to me for people who had fallen out of care and needed to return to care through the linkage program, they could give us a very good referral, because they were able to say, okay, I think Terrell would be a great fit for this client, and here are the reasons. So it provides opportunities for linkage staff to get to know the providers at the various agencies. It provided opportunities for providers to become familiar with the linkage staff, and referrals then, like I said, were more specific and appropriate. And third of all, it provided linkage staff with opportunities to better understand the unique client experience. And again, I cannot overstate how important the shadowing piece was for both the linkage specialists and for helping the community to better understand this program itself and the benefits of this program. Next slide. We're going to move on now to talking about the data collection tools that we used in this program. Next slide. Some things that kind of in hindsight, I want you to think about if you're developing your own program and what kind of data collection that you want to do. There were a couple of things that came up for me where how would I maintain HIPAA compliance? We were sharing information from many different sites, and that was something when at the very beginning I had to work with lawyers at various hospital settings to ensure that it was okay for them, that it was legally, that we were being legally responsible when sharing information. The way that it works in Indianapolis, and that this may or may not be the same in other sites, but in Indianapolis we share when someone enters into HIV medical care, they sign a document that ensures that we can share information between different ASOs. So as a result, the HIPAA issue was not, it turned out that the lawyers with the hospitals were not concerned because that document had been signed. We were able to share that information. We also made sure that once someone was re-engaged, that they understood what was happening and how we were working together. Additionally, we had to think very closely about what information did we want to collect. And as we get a little further into the slide deck, you'll see that what we collected over the course of time has changed. So because this was a significant research project, we were, at the time of research, we were collecting a significant amount of data. And as we moved outside of the confines of the grant, we actually decreased the amount of data that we were collecting. Additionally, something that we really had to think about was, is self-report a reliable source or not? And some of the data that we collected, at times we were seeking self-report data, and there were other issues that we really, sometimes we felt like that data wasn't necessarily something that we could depend on. So really just having these things, thinking about these things as you move forward. Next slide. So we used the main way that we collected data was from clients specifically was through surveys. We collected surveys 4 times during a client's engagement in the linkage program. So again, this was an 18-month program. At baseline, we collected a survey. That survey, also you should have access to this survey, so you'll have an idea of what exactly we were collecting. The survey itself was the same each time over the course of that 18 months, but the baseline survey really guided the linkage specialist in terms of how they wanted to proceed with that, with any specific client, because they collected it during their first or second meeting, and it was a lot of questions about their specific needs, their specific barriers, and that really helped to guide, like I said, as they moved forward in identifying their goals and helping the client to identify their goals, and then also kind of going back to that survey and later saying, okay, so these are things that you identified at this time. Let's kind of take a look at where we're at and reevaluate what goals do we need. We made sure that that survey was available in both English and Spanish, and it was important that when there were certain questions, so the entire survey itself was, all of the data was collected by the linkage specialist and the questions were asked to the client. We had to make sure that when doing training that the linkage specialist understood that they needed to report whatever it was that the client said. So ensuring that they were not influencing the answers. So if, if one of the questions was a health rating, for instance, we had to ensure that if that person said that they were doing well or feeling fine, that was exactly what was recorded, even if, we knew that they had a CD4 count of 2 and a viral load in the millions. Additionally, we made sure that all of this, that unique identifiers were given to each of these surveys, so that way everything was consistent and that it was making sure that it was safe for our clients. Next slide. Because this was part of a federal grant that, as I said, the data was overseen by Johns Hopkins University, there were specific things that we had to collect that included the amount of time from intake until re-engagement in HIV medical care, a number of quality of life measures, and like I said, how would you rate your general health, identification of and ranking of needs and barriers, HIV stigma, retention and care measures, date-tested seropositive, and there was what we found was that many of our clients there was usually about a 7-year gap between when they had tested positive and when they were re-engaging in care. We also sought to identify quality of care measures, so including the viral load, CD4 count, and whether they had engaged in antiretroviral medication. And those were things that I had to collect over the course of time many times, and as well as demographics. I did so by, again, a lot of these things came from the surveys themselves, and a lot of them came from, especially the quality of care measures and demographics, came from accessing medical records. That, in and of itself, was the largest challenge of this entire research project, because in Indianapolis, we have various medical record systems. They don't all speak to one another, and I don't have access to all of those. So that was by far the largest data collection challenge, but it was really important. So that kind of comes back to, is self-report something you can depend on or not? Because our clients certainly were going to the doctor and being given information about their viral load and their CD4 count. When they report that back to me, that was oftentimes not the same thing as what I was finding in the medical records once I had access to those. So you have to really decide ahead of time, what information do you want to collect and how do you want to collect it? If you don't have an easy way to access that information, is it okay to depend on your clients to get that information or not? Next slide. And I think that's what I just said. So identifying a plan for accessing medical records if you intend to gather these data. So really ensuring that you're figuring that out ahead of time. I had no idea when we started this program how difficult it was going to be to gather that data, specifically the medical record data. Because when we started, I had access to state health department data. What I didn't know was that information was, there was about a 6-month lag in that information getting updated, and ultimately that system stopped being updated. And so within year 1, it became impossible for me to access CD4 count and viral load for all of our clients. And so then I had to initiate contact with each of the infectious disease providers and make sure that I was maintaining a relationship with them so that I could continue to access that. But that was a significant challenge. Next slide. In terms of what we did afterwards, as I referenced this before, so once the research project was over, we really had to take a look at what we were collecting, what we needed to collect, and why we wanted to collect it. And also what we found was that as we moved forward, that our caseload, the linkage to care specialists, their caseloads were increasing, and was it reasonable for me to continue to allow them to have increased caseloads and still have that strong data collection? And as a result, we decreased the amount of surveys. The linkage specialists themselves identified what it was that they felt was useful. They said that they really depended on that baseline data to really guide the goal setting that they did with the clients, and it also gave them a lot of information about the people that they were working with, and as a result, they wanted to continue using the baseline surveys, and then for data collection, that I wanted the closure surveys. So really being able to give some longitudinal data. Additionally, I thought it was important to continue to get demographic data so that we understood the populations that we were serving, and for however much it was challenging for us to continue collecting CD4 count and viral load, I found that to be really useful to really, in the end, be able to say, these are the barriers that they've identified, these are the things that have changed over the course of time, and how kind of there was this information, and we were able to pair that with their medical data, and I felt like that gave us a really good sense of the success of the program itself. Unfortunately, we saw a significant decrease in funding for this program over the course. So after the grant itself was over from AIDS United, we still retained some funding from our local funder. However, it was significantly less than what we had sought to have, much less than what we had sought. So that was, in and of itself, a pretty big challenge of whether or not we could continue to collect data at the same level. So as a result, we didn't have an evaluator anymore, and also my position was cut. What we decided was that the most important pieces were the linkage specialists themselves, obviously. So ensuring that that piece continued. We also found we also decided to decrease the amount of service we were providing to the broader community, and decided that we were going to continue to provide linkage support to clients who were part of the Damien Center specifically. So they had to have some sort of relationship with the center. That didn't mean that they had to get their medical care at the Damien Center, but as we got our own medical records system, we were then able to, if they were somehow connected to the Damien Center, then we could ensure that we had access to the data that we needed. Additionally, we loosened the enrollment criteria so that we could serve those people who were suboptimally engaged, because we know that, and we knew this all along in the research project, but there wasn't, because of the confines of the research project, we weren't able to really address that. But understanding that it's someone who was suboptimally in care, so maybe at 6 months you're starting to see that this person isn't attending appointments regularly, and that's really when you want to get engaged with them before they get so far as to fall out of medical care completely. You want to engage with them really when you start to see those red flags, and that's something that we were able to do once we came outside of the research. Next slide. All right, we're going to look a little bit at data that we did collect. I've only put a couple of slides in here, but it'll give you a sense of who we served through this project. Next slide. All right, so this slide shows you the Damien Center in blue. That's our linkage to care treatment cascade, and in relationship to the national HIV treatment cascade. So as you can see, once someone was engaged in the linkage to care program, by and large, they were retained in the program, and they started on, or they returned to taking their antiretroviral drugs, and in turn were very successful in suppressing their viral load. I am extremely proud of this slide itself, and the program, knowing that we were able to really have such a great impact on these clients. We served 187 clients through this program during the research period, and by and large, those people have maintained in care outside of that 18-month period of support, and have successfully stayed in care. Next slide.
Sorry, just give me 1 second, Abby.
Okay.
All set.
All right. So here you can see the demographics. We were, and a lot of this really is in line with, if we look at health disparities in general, we were really, really successful in re-engaging the Black community in care, and that I can't overstate how important it was to have the right staff engaged in this program. Our linkage specialists really were able to build rapport with their clients in a way that was so meaningful that we were able to get them to return to care. Especially of note is that so many of them identified that one of the reasons that they fell out of care was because of their fear of the medical establishment, or more specifically, if they had very specific bad experiences with their previous provider. So feeling like that their confidentiality was breached, that was oftentimes something that they identified. Whether or not that was something that happened or not, that was very much what they felt, and so it made it very difficult for them to re-engage in care and feel like it was going to be a different experience this time. But because they had that very intense and unique support from their linkage specialists, they were able to successfully return to care and maintain. So you'll also see that 60% of our clients were male, 23% female. We also had, we were pretty successful in re-engaging the transgender community, the male to female transgender community, and people who identified outside of the traditional binaries. By and large, for our age demographics were pretty well split up, and we were able to re-engage that younger population very successfully. Next slide. All right, we're coming to the end of this. I was trying to kind of wrap things up so that we'd be able to have time for questions as well. By and large, you can see from this slide that many of our clients lived at poverty or below. As a result, they simply had barriers that were very significant that made it difficult for them to re-engage in care. Many of our clients were homeless, and many of them had substance abuse issues. Many of them had mental health challenges. We saw over the course of time that many of our clients, more and more of our clients, were using meth, and that became an increasing challenge for how do we successfully maintain with these, help these people to maintain in care themselves. But ultimately, that if they did not have stable housing, that was a number one issue for helping them to successfully re-engage in care, was to identify what can we do to support them to become stably housed. Once we do that, then we're able to better serve them and help them to more successfully engage in care or re-engage in care. Additionally, something that comes along with living in poverty, obviously, is lack of transportation. That was, when in the survey data, that was our number one barrier to care that was identified. 63% or 53% of our clients identified transportation or lack of transportation as their number one barrier to care and the reason that they fell out of care. So that was something that was really important through the linkage program, was ensuring that our clients had access to transportation for all medical appointments and all supportive service appointments. As a result, the linkage specialists had to know where our clients lived, or where they spent time, where they could be found if they weren't if they were moving from homeless camp to homeless camp. All of these things were important, and that comes back to building rapport and asking the right questions at the right time. By and large, the education level of our clients were mostly less than high school or had a high school diploma only. And then there's a large chunk of the people that we served who also had some level of college education. But that was just one of the things that we tracked, and so that we would have a better sense of who the people that we were serving. Next slide. All right, now we're going to talk a little bit about lessons learned, and then we'll we'll move it over to the opportunity for you guys to ask me some questions. Next slide. All right, so the biggest lesson learned for me, I think, of all of this was that it takes time. It was really challenging in the beginning, and I got a lot of pushback in the beginning from the community at large in trying to implement this program. There's a lot of data out there now that didn't exist several years ago when trying to identify what does linkage to care look like. People are becoming familiar with that term. There's things you can read about what linkage to care looks like. There's webinars like this, that sort of thing. When I started this project, we really didn't have anything identified as what best practice looked like, and as a result, it took time for me to build those relationships from the state health department. They understood that there were a lot of people who were falling out of care. That was not an issue. That was something that they already understood, but then getting them to give me a list of people who had fallen out of care was a major challenge, because they were identifying because we all share the same funding sources, it appeared as if the Damien Center was seeking to find all the people who had fallen out of care, which, you know, is probably 800 people, something like that. What they saw was that we were trying to pull all of those people into the Damien Center and take all of that funding that goes along with those clients and bring it into the Damien Center. That was certainly not the goal of our program. Our intention was very much to re-engage clients in the best fit way. So if they had fallen out of care at another site, but it had nothing to do with their care that they were receiving there, then really encouraging them to return to their medical home because they had experience there, that was going to increase their medical adherence, and we understood that. So it was a matter of just continuing to have those discussions, and this kind of goes back to those shadowing slides as well, is that as our linkage specialists were seen in the community at these different infectious disease providers or at these different ASOs, then that buy-in happened because they saw the success that those clients that were engaged with the linkage program, as they saw the success that was happening, then that buy-in began to happen. And it was just a matter of really continuing to be there, continuing to show up, continuing to ask for opportunities to tell people about the program, and for me to have strong data that I could begin to show people. As that data were collected, I had to continue to go out to the ASOs and to the state health department and the county health department and make sure that they understood how successful this program was, because from the beginning, our very first client was, he went from he had a CD4 count of 2, he had a viral load in millions, and within 6 months we saw a significant amount of success in getting him re-engaged in care and to stabilize his health. So these were the things that I really had to be mindful of, that I need to be able to show the data in a way that was understandable for different types of communities and make sure that it was relevant to help them to understand the program. Additionally, it would have been good if we had really started to think about what the program was going to look like after the grant funding ended. I think we had really assumed that we were going to continue to be funded at the end of 3 years, that we would have access to other federal funds. That didn't end up happening because AIDS United did not receive the funding on a federal level that they had anticipated, and we weren't really prepared for that. So that had me scrambling near the end of this program to kind of say, okay, this research is ending, what are the next steps, and how can we continue this, because we know that it's really important. We've been able to show that this is really important, and so understanding what additional funding sources were available, that really became very important as we moved forward. And then if we go back to the slides about data, really making sure that you identify what do you want to collect, what metrics do you want to collect, and how do you plan to attain them. And that really goes back to, I wanted to have information, I needed to have and wanted to have information about CD4 count, viral load, and if you're using different mechanisms or medical record keeping programs, how are you going to have access to that? And as a small local agency, you may not have access to that information, and so making sure that you create an MOU or some sort of contract with the agencies you'll be working with or the infectious disease providers, that sort of thing, making sure that you have a way to access that information is really important. All right, that's all we got.
All we got, and that was a whole lot. Thank you so much, Abbe, for a super duper thorough, comprehensive overview, but really amazing, I think, impactful program. We are now opening up the discussion for Q&A. So folks, if you're looking in the WebEx web, you should see up and above to the right an option to click on a blue box for Q&A or a clear box for chat. And we already have some questions that are queued up, and we're ready for you. Michael Stansel asked, when revamping the system, was a client poll used to walk through the system so that they could give you direct feedback on the obstacles that they encountered, or was it based on a needs assessment or a survey interview process of some sort?
So if I understand the question correctly, the survey itself, the survey tool that we used was something that was by and large developed by Johns Hopkins and that was something that was used across all the sites. And so I don't believe that that was something where client input was included in the creation of that tool. But ultimately, it ended up being a really useful tool. We were able to add some questions into it that we wanted to ask that we felt were relevant to our sites that we would be serving. But as we moved forward, we used that survey tool as something to guide practice. And so really ensuring that the clients that we were serving, if they identified these specific barriers, and there were options in the survey as well for, open-ended questions, and or if, there was a barrier that wasn't part of the list that could be added. And then really making sure that that really guided practice as the linkage specialist moved forward in each specific situation.
Okay, so it sounds like it was tailorable at least to some extent.
Yeah, I mean, I think you're right, though, that it makes a lot of sense to have your client engaged or some sort of focus group engaged in the creation of tools like that.
Mm-hmm. A question around sort of follow-up planning, what's next contingency plan, which is one of the last slides you presented on. We have a panelist who asked, in hindsight, what are a few plausible options that you would have taken for continuing this work in terms of sustainability?
So we were fortunate enough to continue to be able to fund the linkage specialists. I think that what I expect to see as we move forward from a federal standpoint, I expect to see red and white coverage to include probably federal funding for patient navigators or linkage specialists, something that will look very similar to what we were able to do, and hopefully we'll be able to continue doing something like this. I'm not sure that the scope of we were very, very fortunate to have so much money to be able I mean, it's not something that people are going to be able to do at the same level as what we were able to do because we were able to do large-scale advertising campaigns. We were able to really provide a lot of support to each client because of the funding that I had, and I could tailor that in a way that I don't think is reasonable in a real life setting, but I do think that it was important that it would have been smart for us to really be looking at what were the next steps before we got so far along.
Speaking of marketing, a participant has a question sort of around how you were able to subvert HIV stigma, because so much of what the Damien Center does sort of has HIV involved in the name and in marketing and messaging. What were some of your strategies for recruiting folks while sort of dealing with stigma?
That's a great question. Yeah, the Damien Center is certainly known in Indianapolis as the AIDS place. And so we had to acknowledge that from the get and understand that not all people were going to be comfortable coming to the Damien Center. And so that also ties into those really strong partnerships that we built in the beginning with our grantees. And so especially for the Indiana Latino Institute and Brothers United, making sure that that the linkage specialists were able to create space for people who might traditionally not be comfortable coming to the Damien Center to have some sort of safe space that they were able to meet with their linkage specialists. And that meant either going to those agencies, or oftentimes it meant meeting the client in the community in a space that the client had identified that was a safe space for them. So that could be their home, it could be McDonald's, it could be the library, whatever it was that was going to work for that client, and really allowing them to guide what that looks like, and then also making sure that they connected to a medical provider that was the best fit for them. So if they would feel more comfortable being seen at, in a large hospital setting where it wouldn't be necessarily identified that they were HIV positive, then that would be a better fit spot for them. So I think that those are a couple of ways. So that's kind of how we tried to tailor what services look like. And in terms of decreasing stigma, I think that that very strong relationship that the linkage specialists made with clients themselves, that also really helped people to work through some of their internal stigma that they were carrying. From a community standpoint, I'm not sure how much we did I think that we helped people to re-engage in care, but I'm not sure that, the large-scale advertising we did, that helped. It certainly increased communication in the community. It brought questions up about HIV. People called to get more information. It significantly increased testing as a result. But again, I'm not sure that was not necessarily a specific aim, aside from helping our specific clients to re-engage in care.
Gotcha. Last question around compliance, and you mentioned that some sort of a flag in terms of challenges. One participant asked, what were some of the challenges that you encountered with maintaining HIPAA compliance when working with so many partners? And they specifically asked, particularly in the earlier part of the program, when you're sort of just getting this off the ground.
Sure. Honestly, it wasn't a large challenge for us, I don't believe. Making sure that, especially with the survey data and that sort of thing, making sure that the staff that I was working with understood what was expected, that they needed to have, that information needed to be stored in locked spaces, they needed to have HIPAA-compliant computers and servers and that sort of thing. But because the way that it works in Indianapolis, we're able to share information cross-site. And so that actually made it much easier for us than it could, I think, in in certain situations. One of the challenges certainly was that that our linkage specialists did use non-traditional methods to connect with their clients. So things like reaching out to them on Facebook if they had stopped attending appointments or they couldn't reach them because their phone was, because the client phone wasn't working, something like that. Then, so that was something that had to be something that that the client had agreed to ahead of time. So making sure that they had signed some sort of waiver saying that, it's okay for us to text, it's okay for, or what things are okay, and making sure that that had been identified between the linkage specialist and the client ahead of time, so that, and it also included, and this isn't HIPAA compliance per se, but part of the training in the very beginning for the linkage specialists was you need to be having talks with clients from the beginning. Is when I see you in the community, how do you want me to engage with you? And that really is, so making sure that this was very much guided by each client in identifying what was going to work for them.
Gotcha. Abbe, I feel like we could talk to you forever. This was such a helpful and informative webinar. Panelists, you are the panelists, but attendees, we want to thank you so much for joining us as well. Abbe Shapiro's contact information is here, and we hope you'll join us for our next upcoming webinar on July 8th. Well, Abbe will be here again with Terrell discussing more of the great linkage to care work being done in the greater Indianapolis area. Everyone have a wonderful Wednesday, and Abbe, thank you again for joining us. We'll see you next time.